fearing movement or weight is a somewhat ATS view of medicine.
Do you think that traditionally traumatology has had a weakening approach toward the population?
Absolutely, yes, but the problem is that there are many types of doctors who don't.
Define what it is and how to know if I have it or not.
Sarcopenia. Sarcopenia increases mortality rates dramatically.
What other daily risks does someone with sarcopenia face?
The woman returns months after discharge with a badly oozing infected wound. The patient dies. And now the paradigm has changed.
Have you heard of many orthopedic surgeons who are in favor of running?
Our joints are made for impact.
Children who train with weights end up short.
That's a lie. In fact,
What are your top 3 tips for someone?
especially about strength and related nutrition.
Ines Moreno, traumatologist. Welcome. Better than yesterday. How are you?
I'm very well and happy to be here. Thank you for inviting me.
We have a script today. Have you seen it? It's spectacular. Plus, it's between Andalusians, so I'm really excited. Neighbors, almost neighbors. Granada-Malaga connection. Also, Danny, remind me, I think she's the first traumatologist to visit us, right? Yes, the first. No, Carlos was an anesthesiologist. She's the first traumatologist. So, you're representing your specialty for the first time, no pressure, after 102 episodes. Around there, 122 episodes. I'm really looking forward to it. Like I said before, I don't see many orthopedic surgeons who do outreach. There are some, but your outreach really caught my attention because you use a tool in digital marketing called storytelling, which is wonderful because it makes people remember the stories, and besides, you tell them so well. It's clear that you're passionate about it. I mean, that really comes through. How did you start doing outreach every day? Why and how?
That was after a morning consultation with over 20 patients. I was always telling the same story, like, look, this is how the joint works. You have to do this, you have to do that, and we usually leave the consultation room door open. I don't know, we have a common staff hallway where the assistants and nurses are, and we ask for something if we need it. So they would hear the stories I told the patients, and they would say, oh, this is interesting, you should tell it. And one day after finishing work, also the first video is out there in the locker room. After finishing the consultation, I came out and said, I'm going to tell you this. And I did it a little secretly because I was really embarrassed. And I thought, well, if nobody sees this, then I'll just close the account.
And that's it, nothing happened.
And it turns out that with just one video uploaded that afternoon, my mom asks me, Inez, are you the geek traumatologist? I said, what? She says her friends messaged her about you uploading a video. So the first video already,
Without my anonymity,
it didn't last at all.
do you remember what you said in that video?
Well, in that video, I talked about calcium, the calcium deficiency in the population, and which foods from their kitchen they could eat to make up for the calcium. Let's say,
Ah, that's great. So today, do we have 500,000 followers or more? No? Yes.
yes, I also have about 180 more on TikTok.
That's a record. That's awesome. Well, it's clear that you enjoy it, and that comes across on the screen. Let's get started. I'm going to ask you about your specialty, and sometimes I ask tough questions, okay? Don't worry, we need to dig a bit. Otherwise, the episode... So, do you think that orthopedics has traditionally had an approach that makes the population more fragile, or has it made us more fragile?
Absolutely, yes.
All right, I like that.
But I also think it's a little bit the fault of all the specialties, and let me explain. Medicine in the 80s was highly paternalistic, focused on controlling and directing patients. It's true that our current approach focuses more on the patient. Or at least what I look for is that the patient takes part in their own health and that they also understand that there are aspects that depend on them. But yes, we've been very much about, don't do this. We've had some misconceptions about traumatology, which are now being corrected, and all of that has led us to be a bit...
Yes, we'll cover that now. But I feel like among specialties, traumatologists are the ones who say, don't do this, don't do that. Strength training, be careful with your spine, and so on. It's been like a figure of authority, a lot of authority, who has even sometimes taken a stand against many sports or physical activities that have been proven to be beneficial. We'll go into more detail because there's a term that's been talked about a lot lately, which is kinesiophobia, the fear of movement. So do you think these attitudes can contribute to that kinesiophobia?
Of course, I think that the fear of movement, the fear of weight, is a bit of an old-fashioned concept in medicine, because there are already many studies that disprove that fear of movement, that fear of exerting force, and there are many testimonies as well. We'll get into that a bit later. Even for the spine, once considered off-limits for strength training, it is now being used as treatment. The problem is that people who don't exercise don't recommend exercising, following the example of doctors who don't really exercise much themselves. So those people aren't going to understand, because they're not going to connect, let's say, with people who like sports and actively participate in them.
Although I should also say I've met many orthopedic surgeons who are very athletic. Today, I'd say it's among the most athletic specialties.
The paradigm is changing quite a lot.
Mostly endurance athletes, but also some variety. I have friends in CrossFit and trauma specialists. I think, like other specialties, they are joining the improvement movement. Thank goodness. Now let's talk about a disease that involves many specialties, which is sarcopenia. You did your thesis on sarcopenia, right?
I'm still working on it.
Great. If you like, explain briefly what sarcopenia is and how to tell if I have it.
Sarcopenia means muscle loss. Sarcos is Greek for muscle. Penia means lack. So basically, that's it. There are more and more cases every day because the main factor is the patient's age. And that's something you can't really influence, but you can reverse it and prevent both things. So our main goal is to determine how many people have less muscle than they should, because it's not a simple thing. There are a lot of older people, and in fact, very soon, 1 out of every 3 people over 65 will be affected. We're making great progress, especially in Spain. So first, it's about defining how many people have muscle deficiency. For that, we're using scales from many different places. We're trying to figure out how to measure sarcopenia, because that's the first problem, of course. There are easier parameters, for example, measuring the diameter of the quadriceps, which is actually quite simple. Another one we use is grip strength, because it's no use having 20 kilos of muscle if your grip strength is weak. And then there's another one, which is impedance. Those scales where you have to be barefoot, and then there are more complex things like DEXA and so on. What we're trying to do is, let's say, avoid having you get a scan to know if you should have more muscle. Instead, it should be as simple as standing up, sitting in a chair, or walking 100 meters. We measure all those things, and with that, we can determine if you have sarcopenia.
These functional tests are common in trauma consultations.
No, not at all, not at all. That's the intention, to try to incorporate them, to make them as simple as possible, and to have some guidance, because I have seen that they do help. I've experienced it myself, not just read about it. Sarcopenia increases mortality by huge amounts. I remember I operated on a hip prosthesis, and in the approach we usually take, in the cuts we make, okay? One of the muscles we see is the gluteus medius, but there was a patient who had a very atrophied gluteus medius. There was hardly any muscle fiber, it was all fat. The woman is discharged but returns months later with an oozing infected wound. The patient dies, and I just say, well, that's it, I don't know about the hips. 50% die in the first year, so it's a fracture. And then a few months later, another patient comes in with another hip fracture. That was more serious since she went to the emergency room and wasn't seen. She had gone home, and I saw her in my office a week later, and that's when we saw the fracture. So she had been waiting a week to have surgery. She had surgery, I operated on her, I saw the muscle, which had significant muscle fiber, there was hardly any fat. I thought, that's good, this woman is fine. I closed up, left, and then she also came back to my office complaining. I thought, oh no, bad luck, I hope she doesn't end up like the other one. But no, it's just a superficial wound. It closed well, healed perfectly, and the only plausible difference was that I saw an exceptionally fibrous muscle. One waited a week for surgery, which went well, while the other had surgery the next day. No delay or issues, same complication.
Of course, because I remember that, well, one of the conditions that is sometimes required to perform a certain surgery was the body mass index, Because in patients with very severe obesity, the surgical risk...
Anyway, body mass index is a parameter that I haven't mentioned to you, because there's something called sarcopenic obesity, which you probably know what it is, which basically means that instead of muscle, I have fat. So that fat is weight, it contributes to the body mass index, and can I have sarcopenia? Can I have obesity?
Yes.
That's usually the case.
Also, let both of them go.
In that case, body mass index is appropriate, but mainly reflects fat loss, not muscle, since muscle is much denser.
Of course, what I meant is that besides evaluating body mass index or the fat component, you also have to assess, because of the surgical risk, the muscle component and muscle function. I think that's something that should always be done in medicine and especially in surgery. Sarcopenia, it's something that only happens to very elderly patients, to grandpas or grandmas who have weak muscles. Or is it appearing more in younger people now?
That's another common myth, and we want to dispel it during the consultation, which is that muscle loss starts at 30 in your early 30s. So at 40 or 50 years old, you could be sarcopenic. The problem is more people stop exercising each day because our environment isn't exercise friendly. So is it true that the prevalence of sarcopenia is increasing?
Here, only exercise helps. There are no supplements, no pills, no key foods that will prevent you from losing muscle.
Staying active through exercise. We did a study because also within the context of the thesis, we are conducting studies looking for sarcopenia in the general population, and we selected random people. We gave a sarcopenia test to people from the province of Jaén. All of them were over 60 years old, and we found that 7 out of 10 had sarcopenia.
7 out of 10 in the province of Jaén.
People over 65.
People over 65, 7 out of 10.
Then, during hospital admission, length of stay is linked to sarcopenia, and 80 to 90% of admitted patients may have it.
Almost all of them. Almost all. Okay, well, hard data, right? And what is exposed? Well, let's say it clearly. You've already said it. Greater risk of death during or after surgery. What daily risks does someone with sarcopenia face? I don't know. Think of the most everyday things.
Fracture. The amount of muscle and the amount of bone go together. Do you see the connection? Yes, actually, this has come up recently. Regarding the muscle-bone index, what if my muscles are very strong? The bone must grow with the muscle, so muscle contractions don't break it. Exactly.
Right. Strong muscles pull on bones, making them stronger. There are also myokines and osteokines that interact.
Actually, we often see the fracture people get from arm wrestling.
Arm wrestling, yes, of course.
Because they push their strength beyond what they can handle. So with the muscle contracted, they lose and the humerus breaks.
Do you see fractures from arm wrestling?
Yes, quite a few. Please don't do arm wrestling.
Are there world championships for arm wrestling? I follow a guy who's a world champion. His name is Devin Larratt, and his forearm is bigger than his arm, literally. And it's amazing to watch him.
If he loses, he should do so with dignity, right? With a humerus fracture, they're spiral fractures, and they're quite difficult to operate on.
Ugh, so they make a spiral in the bone, right? Damn, I didn't know there were so many fractures from arm wrestling. Yeah, interesting fact. What 3 tips would you give to reduce the risk of sarcopenia over a lifetime? I know them, but still.
Yeah, well, exercise, that's the first and most important one. Honestly, without exercise, there's nothing.
What kind of exercise?
Well, mainly strength exercises. Although actually impact exercises also work for me. Okay, so running, for example, which they're doing in 8th grade. I like orthopedic doctors a lot. A nutrition plan to go along with it, okay? And basically, I have more than enough advice. With those 2 pieces of advice, I already have it covered.
They're the most important, right? Yes, they're the most important. We'll discuss running later. There's a lot to cover as an orthopedic doctor.
To talk about.
Not perfect. Look, let's play that between topics. We include some of your little stories that I really like. You've told a lot. But there's one that first caught my attention, which was the grandmother hypothesis, because I really like that hypothesis. I mean, it makes a lot of sense. I studied it too, but can't recall what I was preparing when I found the grandmother hypothesis. Studying gallows is also logical. Does it relate to the grandmother hypothesis? Because killer whales are among the few mammals that also have a relatively early menopause and many years of menopause, right? Grandmother killer whales are very important. So explain how the story of man as provider is false and what we've been told.
Yes, that story seemed unbelievable to me. And I read it from Arswaga, who brought it from a woman at Harvard, who was the one who did it first. And basically, she wondered if we are born, reproduce, and die, why do we stay alive after reproducing? A lot of years, of course.
So?
Apparently, she has also studied populations of the Hadza in Tanzania, which are groups that still live in a way very similar to how hunter-gatherers used to live. And her What she saw was that in the tribes where there were many older women, because at 50, a woman's main role isn't having children but caring for her grandchildren. And gathering food, right? When a woman of childbearing age doesn't have to worry about gathering food, she can have more children. Of course, if that woman experienced it, the first thing that happens is that the time between births is much shorter. Since they reproduce more, they have more children.
The group
Does better, the group gets bigger. And so that's what Grandma provided. She was a reliable source of food. Because in the end, what happened in the Paleolithic was that the guy would go out with the spear, spend 5 hours outside, and come back with the spear exactly as if nothing had happened.
from time to time.
He sometimes caught something, but usually returned empty-handed. Then it became clear that the grandmother's role, above all, is to shorten the time between births. The group grows more. And so, in the end,
grandmothers played a fundamental role in providing logistical support by contributing food and relieving the mother of some caregiving duties so that the mother could expose herself.
they also did medium and small game hunting, so that also breaks the conception, the one we had for a long time, that the hunter was the man, women. I mean, the hunter wasn't just not a woman, it was the grandmother. On top of that, it breaks a lot of stereotypes.
Yes, and it also applies to some animal species like orcas. Grandmothers, for example, teach their grandchildren and children how to hunt, so they're also in charge.
Of course, that's the case in a species like humans, who take a long time to become independent, because a gorilla is independent. In just a few years, how long does it take for a human? 6 years before they can talk, move on their own, be self-sufficient? A long time. During that time, the mother couldn't be watching all the time.
I imagine that here we can talk about grandmothers and grandfathers because I understand that in Lojasa, when the grandfather reached 70, he wasn't going to pick up the spear either. Was he going to chase big animals at that age?
But is it true that men, as men, remain fertile for many more years? I mean, from an evolutionary point of view, a man shouldn't stop existing after a certain age.
Of course, yes. Very interesting, very interesting. Let's move on to new paradigms. In traumatology, it has always been thought that osteoarthritis was simply due to the use of the joint. And this leads to wear and tear, like a car tire that wears out with mileage. Is this view changing?
This view has been changing for about 10 years more or less, since I was finishing my degree. It was already starting to be said that osteoarthritis is not so much a mechanical phenomenon, but rather an inflammatory phenomenon that falls within inflammation. It's low grade. In principle, our joints are made for impact. That's like when people have Alzheimer's and they're told to do brain exercises and start doing memory exercises. Telling someone with osteoarthritis to stop using the joint is like telling someone with Alzheimer's to avoid brain exercises to prevent fatigue. It's the same with sarcopenia.
Don't exercise.
People avoid exercise, but they should do the opposite. I mean,
inflammation is one of the promoters of osteoarthritis, and anything that increases low-grade inflammation, whether it's a disease, obesity, or whatever, contributes to it. I see.
Actually, there are many. Well, there were a lot of studies being done that basically involved taking joints, injecting them, and measuring the inflammatory factors. So it was found, for example, that the best way to measure the progression of osteoarthritis, better than X-rays, better than magnetic resonance imaging, is the elevation of interleukin.
6, okay? So, one of the best predictors of osteoarthritis is interleukin 6, which, if I remember correctly, also increases with exercise, right? But, I mean, interleukin 6 was the one that was good in the short term and bad in the long term.
It increases chronically, and tumor necrosis factor alpha also rises significantly in osteoarthritis.
Is there another one?
One of the most groundbreaking approaches right now is that there are several studies being done that are X-rays of osteoarthritis. Are they tracking how the X-rays evolve with the treatment using glucagon-like peptide? 1. And so they're seeing that before the weight loss even begins, the inflammatory markers are already reduced and the osteoarthritis improves, even without any change in weight.
Joint changes occur even without weight loss.
Yes, there are the photos, and the problem with glucagon-like peptide, 1S, is that they cause muscle loss.
That's not...
We haven't solved it, so...
They're working on it. So there are new drugs in development that they want to combine with glucagon-like peptide, 1S, to prevent weight loss. That's on the way with myostatin inhibitors. Let's see what happens.
Right, I've read about it and I find it super interesting. But what more proof do we need that osteoarthritis is a more inflammatory process than a mechanical one?
Therefore, telling someone with osteoarthritis not to move is usually counterproductive for the pathophysiology of the disease. No, it's another thing if the pain is so disabling that, well,
Progressive exercise, just like someone with Alzheimer's does Sudoku and simple exercises. You can't expect to run a marathon with knee osteoarthritis. You have to do progressive training. Okay?
movement, when it causes pain, is one of the reasons why people don't exercise. It doesn't hurt to move, it hurts, so I don't move, but movement can also be an analgesic.
Let's see. First, you need to know how to distinguish the type of pain. If I have a mild pain that allows me to keep playing sports, and when I finish exercising, the pain goes away, then it's simply a mild pain. The problem is if I feel pain during exercise, I finish, and the pain worsens or lingers. Several days later, well, obviously I've overdone it, but a mild pain, especially when we're coming back from an injury, that's going to be there. The point is not to overtrain. It's proven, which is why we strongly recommend it, especially for those who've just had surgery. Physical exercise produces a series of hormones that, besides activating reward circuits, inhibit the pain stimulus, because the pain stimulus has mechanisms that turn it off. Also, the pain stimulus depends a lot on the central nervous system. You can activate and inhibit it yourself, even if the pain stimulus itself doesn't really change.
No, this would take a long time. Do you think that the new traumatology, let's put it that way, is becoming less and less intense? Have you presented? Do you have any of the short ones who like to put in nails, who like to do that? But sometimes the answer is not to do anything, or sometimes the operating room is not always the solution. I think I remember that a new procedure came out recently. I don't know if it was for the anterior cruciate ligament.
Well, we can talk about that.
We'll discuss it when it comes to mind.
Traumatology has gone through several phases. Let's say that for us, the magnetic resonance imaging has been one of the most controversial videos that I uploaded. Considering if we'll actually do magnetic resonance imaging, let me explain. In the 1980s, when MRIs started to be done, when the price began to drop, they started to become affordable. When they started to become affordable, MRIs started to be done, a lot of them. Knee pain, magnetic resonance imaging, back pain, magnetic resonance imaging, and every injury we saw, we had to fix it. We went into a frenzy, like when all you have is a hammer, everything looks like a nail. We used to fix a meniscus if we saw one, or a hernia if we found it. Now the approach has changed because of our dedication. We've also done a lot of magnetic resonance imaging studies on healthy people, and it turns out that there are meniscus tears in people all over the world starting at age 30. Partial rotator cuff tears all over the world, and hernias too. The paradigm has shifted. Seeing an injury doesn't always mean we need to treat it. But many times we're actually seeing more than we probably should. Thank you.
So yes, we choose a less interventionist approach when there are no symptoms. When there aren't any, yes.
Finding a torn meniscus is like spotting a gray hair. Joints age, and then it's like they get a wrinkle. Yes.
It's an important change of mindset, especially nowadays. The general population gets a magnetic resonance imaging of their spine and sees a bulge or a hernia without symptoms, and they change their behavior. And I have friends who have stopped playing sports, or, well, not sports, but certain movements, simply out of fear, even though they don't have any symptoms.
That's the problem. If from the age of 30 there is a high prevalence of meniscus tears, which is almost 25%, try telling a hunter-gatherer population to stop hunting after the age of 30 because they have a torn meniscus. No, of course it's that ridiculous.
Okay, what about the Bolsa de Bogotá? That reel was also very successful.
Well, that's also from the 80s when the guerrilla groups in Colombia were at their peak. And so there were daily car bomb explosions, attacks with shrapnel. So there were huge abdominal wounds, and one of the problems they had was that, of course, they had visceral injuries and had to operate. They had bellies, and what about the bellies? It's just that if you had lost a lot of skin, maybe from an explosion or a bullet impact or whatever, all the area that has been burned, that skin has to be removed. So, of course, if you try to close that wound again, The skin doesn't stretch that much. If you close it tightly, the diaphragm can't lower and he suffocates, but if you leave it open, it can get infected, which is also bad. What do you do in that situation? A Colombian surgeon was in the operating room with one of those cases after already operating for 4 hours. He says, now what do I do? Me? Do I leave it open or close it? Then, regarding the intravenous fluid bag dripping to the patient, he asks, that bag is sterile, right? They say yes. Then we sew it onto the belly like a window.
Of course, we open and close.
Of course. We see how the belly is, and if later on the ward I see that it's better or worse, then I just... And since it's transparent, they can see how the healing is going. In fact, that's now used in traumatology. We have transparent dressings on the ward, we cover it. The wound is isolated from the outside because it's sterile, but you can see the wound if there's pus, if there's no pus, if there's blood.
A genius. That's a good observation.
And above all, cheap and clear.
Some of the best discoveries are those that are cheap and brilliant. There's nothing else like it. All right, Ines. Now we're going to get into some myths. In traumatology, there are many. I think I've reviewed the most common ones, at least the ones I hear most from followers, friends, and my close circle. You'll explain if they're myths or not. Some may not be myths. You'll let me know. The first one is that running is harmful and destroys your knee. So far, I've heard very few traumatologists who are in favor of running.
Well, I must be the odd one out, I am. Sometimes I feel like Don Quixote fighting windmills all the time. Because I don't just think that running isn't harmful, I actually think it's good for you. In the sense that it's an impact exercise. It boosts muscle mass and bone density, with running and jumping rope being the best exercises for bone density.
Of course, you have to get used to the impact.
Because of the exact impact. Wolff's Law, which I cover in a video, states you have as much bone as the exercise you do. So, for example, the samurai had shin bones that were almost entirely cortical. It was all hard bone.
Why?
Because they trained a lot, and with a lot of impact, they would jump from rooftops like children. Does that count?
I mean, well, there's no need to be afraid of running, obviously. You need to have strong muscles to support that.
The only exception is, well, to have training, a progressive adaptation, let's say. It's recommended that you don't increase more than 10% of your maximum weekly distance. There are studies with nearly 200,000 patients. I even made a video about it, using footage from an orthopedic doctor. He said, look, I'm operating on a knee, so you shouldn't run marathons. I shared that video and said it's false.
Of course.
Because studies of over 200,000 patients examine osteoarthritis rates based on whether they run. Among sedentary people, about 10% had osteoarthritis, including young individuals. How many marathon and long-distance runners do you think had osteoarthritis?
How much? For the sedentary, 10%.
Approximately among young people?
Has less.
About 3%, yes, 3%. So what really increases the rate of osteoarthritis is in professional runners. You can see these are people who already...
Yes, well...
I can imagine the volume?
The volume of an ultramarathoner, well, yes.
Of course. But the runners they call recreational, well, people who run on the weekends do a long run, and during the week do shorter runs. Those people greatly reduce osteoarthritis.
So therefore, the impact is not necessarily harmful to the joint, but actually, as you said, it can even benefit it.
I always tell my patients this in my office, and people like it because it's visual. It's that in the rest of the tissues in the body, a blood vessel comes and delivers the blood. And that's where the nutrients go, and the oxygen and everything else. But that doesn't happen in the joints. Joints are what we call avascular. It's a fluid sac with no blood flow in or out. That's just the fluid, meaning the only way for that fluid to be renewed and for new nutrients to get in is through movement. All those injections we give of hyaluronic acid, that's nothing more than the acid that naturally exists in the knee. I make it in a lab now, though it was once extracted from rooster combs.
It comes from rooster combs.
The first ones did, but not anymore. So what about that? It was found to have properties similar to joint fluid. If you want a daily dose of hyaluronic acid with daily exercise, do you need to see an orthopedist for it?
So, is moving a joint the only way to nourish it long term? Basically...
Absolutely, yes, that's right.
Swimming is the best, most complete exercise and has a unique connection to orthopedic doctors.
Win. The problem is the older population segment, which is public knowledge. We've lost it, we've lost it. And there, water gymnastics has been taken over by the famous aqua gym, of course. Everyone is there. And the only ones who have paid attention to people over 60 are those in aqua gym. There isn't any functional training for older people, so they haven't won there. I do enjoy swimming for injury rehab. It's true that recent studies say that while you don't gain bone mass, you don't lose too much either, so it can help maintain it, but it's true that it has little impact. So if what I want is more muscle mass and more bone mass, it's not the best sport, but it's good for rehab.
That's like cycling, right? The sport is old.
But I really like cycling, unlike swimming.
Yes, but for osteopenia and osteoporosis, it's not very helpful.
But cycling, specifically for femoropatellar osteoarthritis, seems amazing to me. It prevents a lot of injuries. Thank you.
Okay, kids who train with weights stay small, they don't grow.
That's a lie. In fact, because of that fear of weights in kids. Well, it's been seen, for example, that right now there are a lot of anterior cruciate ligament tears happening in kids. In fact, one of the main topics at almost every trauma conference is, how do I repair an anterior cruciate ligament in a child without causing harm? The growth plate. Why? Why? Because for the anterior cruciate ligament, the growth plate is very, very close. It's about inventing new techniques, but could we act sooner if children began training earlier? Quadriceps protect and compensate for the anterior cruciate ligament's function. And also we would create, adherence to sports. Would they integrate it? Exactly.
So it's not just playing soccer or basketball, which is great, but there's so much more a child can do, and there's no need to use heavy weights or anything like that. What I mean is when a child jumps off a chair to the floor, he's receiving load.
Right? So...
Okay. Another very, very big fear is the deadlift. The deadlift is a direct ticket to messing up your spine.
Well, absolutely not. The problem is those myths, like the one that says your knee shouldn't go past your feet. Well, of course, if my femur is long or my torso is longer, inevitably my knee has to go past my feet. If I'm focused on preventing that, the only way I can deadlift is by hyperflexing my spine. I create a big lumbar curve, and that's definitely a ticket to injury.
Of course.
So, not all bodies are the same. It's just that on social media, I make up an axiom that works for everyone, like the knee shouldn't go past the foot. I make 3 videos, and because they're impactful and unexpected, those get promoted and seen, but that's not reality.
Of course, that happens in every niche. The topic is also intense. I get a magnetic resonance imaging, I have a bulge, a hernia, I feel great, but they tell me I can't do strength training.
Of course, that's another one of the myths, right, in traumatology. The spine isn't that useless, okay? There are many bulges that don't cause any symptoms. There's a ligament I show in all MRIs, the posterior longitudinal ligament, which acts as an emergency wall against a hernia. So I can have a disc that's bulging, but that ligament is holding it back for me then. A similar thing happens in the spine as in the knee. The stronger my quadriceps, calves, and other dynamic knee stabilizers are, the less strain on the meniscus and the longer it lasts. The more paravertebral muscles I have, the less the disc will have to work and the more years my disc will last. So it not only prevents, but it's also a treatment. Actually, it was funny because I wrote an article in Ideal about low back pain. What? This has resulted in several videos of people sharing stories like, I cured my low back pain by exercising, since I was specifically discussing exercise as a treatment in that article.
Yes, it totally changes everything we've been told up until now. Thinking is another thing. I think cartilage is one of the tissues that is least understood. Think of cartilage like a tire that wears out over time. It has about 10,000 kilometers, and at 10,000 it's finished. You no longer have cartilage. But it's not like that. There is a way to keep cartilage functional and healthy with a lot of durability throughout your entire life.
Look, there is a genetic factor that's important, between 30 and 50%, but that mostly happens in the knees and thumbs.
In knees and thumbs.
Yes, rhizarthrosis is very genetic. I tell my patients that some people inherit olive trees and some inherit rhizarthrosis.
I wish.
But that's more or less how it is. But then the problem with the X-ray is that not everything matches the clinical picture. I've had patients with terrible X-rays, I wish. For example, not long ago I had a case in the office, and since we have a bit of a waiting list, a female patient came to me with a knee issue. At its maximum degree of osteoarthritis, we measure osteoarthritis in 4 grades. Well, she had grade 4, which is the highest. I told her, "Mom, you already have surgery approval. When would you like us to operate?" She replied, "No, I don't want surgery." I asked, "What?" She explained, "Yes, I was caring for my mother, but she recently passed away. Since she left, I've been exercising and feel much better."
I mean,
She gave me everything I share about how you can have a terrible X-ray, but with exercise you might not need surgery. She taught me that in just 5 minutes of consultation.
yeah, sometimes, well, cool, that's good. There are a lot more myths. I don't know if you can think of any others, because from your perspective as a traumatologist, maybe we're missing something right now.
Cartilage, the big one, also. The famous cracking sounds, right? Yes, my joints and fingers crack, and people ask about the cracking sounds.
Does that mean there's a pathology or a problem?
No, actually, there's a funny study by a guy, maybe an orthopedist, who did this experiment. I can't recall if it was 15 or 20 years cracking the knuckles on just one hand, not both. And after those 15 or 20 years, he started getting X-rays. And he said there were no minimal changes. I mean, it was exactly the same.
He had continued to be randomized in his body with a normal hand.
Well, it's a blind study, and no. But what I mean is that those cracking sounds, which people think might be pathological, are often just small air bubbles in the cartilage fluid. It's very common. The menisci are mobile, so it's very common that maybe I make a slightly unexpected movement and catch the meniscus a little bit. It's something momentary. It might crack and that's it, or maybe the tendons are very close to the joint, so at some point on some bony ridge, well, it might make a slight cracking sound, and most of the time it doesn't have any consequences. The only cracking sounds that would worry us more are the ones that leave the joint, let's say, locked. Of course, that's the only cracking sound we should be concerned about. All the others are not a problem.
All right. Why is surgical clothing always green or blue?
I thought that was amazing, and I never understood why people didn't talk about it. Or maybe it's just that no one has stopped to think about it. If you look at a red stain for a long time, and then look at a white surface, I don't know if it's happened to you, but the red stain keeps appearing to you. Yes, it appears, but it appears in green or blue. Yes, it appears in a dark color. At first, operating rooms were all white because of cleanliness and hygiene. But of course, if you spend a while looking at intense red and suddenly look away, the white starts to look green and blue. So they said, maybe this is what's happening. When you, after seeing that, looked again, well, that would cause eye fatigue.
The intense red of the blood.
Of course, the intense red when you look up because you keep looking up to grab instruments, to adjust a lamp. If you looked up, you saw white, the red spot stayed in your vision, then returned, causing significant eye strain. So what they discovered is that the spots you see afterward are red. Sorry, they're green-blue. So they discovered that it was the chromatic opposite of red. And it's true now that I think about it. When I look away from the surgical field to grab some material or to change a light or to do whatever, then you look back and there's no residue at all.
So it's a matter of making the surgeon's job easier.
But these are things that don't seem to be important.
If you spend 7 hours operating, you can see how important they are.
7 more?
Depending on the type, what's the longest surgery possible?
Specifically, in my specialty, it's scoliosis spines.
No.
Yes, scoliosis cases that require fixing many levels. It requires having the patient monitored at all times, and we can be in the operating room for 12 or even 16 hours.
16 hours, I mean, practically a whole day. Yes, that's unbelievable, my goodness.
Yes, because these are surgeries that have to stop as soon as the electrical signal changes even a little. We must stop, assess our actions, undo them if needed, and this has increased for everyone. Clearly, there is more than one surgeon. You can take a break to use the bathroom or eat, then wash up and return. We're not there for 16 hours, but small things like the color of the operating room clothes really help.
Of course. Regarding osteoarthritis, for example, many people wonder if it's hereditary. My mother had osteoarthritis and was in very bad shape by the time she was 60. Am I going to have it too?
There are always non-modifiable factors, which in this case would be heredity, and modifiable factors. If we've said that muscle strength and exercise prevent and treat it, then you might not get it if you have adequate muscle support. But also, even if you did have it, right? A big part of the treatment involves exercise, but it goes even further than that, even more. In patients I've seen who needed a prosthesis, it's like, wow, everything failed and we ended up with a prosthesis. I get those patients up right away. I have them walking within 24 hours and riding a bike by day 15.
Prosthesis?
Yes. I keep breaking through.
Well, I really don't know about this, but prostheses also work better the more exercise the patient does afterwards.
There are many types of prostheses, but basically, the anterior cruciate ligament is removed, okay, and the more internal collateral ligaments are also removed. Some prostheses preserve the posterior cruciate ligament, while others remove it.
And what about stability, the knees?
So it's based on polyethylene components, meaning plastic, and there are also muscular components from the patient. I'm telling you this as more than just a treatment. It's just that if you start doing your muscle training, your impact exercises, and your osteoarthritis doesn't improve. We'll give you your prosthesis, but you have to keep exercising, because that prosthesis will work better the more you exercise. People often visit my office showing videos saying, I'm riding a bike with my prosthesis.
Good. And that idea that joints or osteoarthritis hurt more when it's going to rain, is there any truth to that?
Well, it seems like there is, or
It's not just an old wives' superstition, right?
it seems that studies have been done with quite a lot of people, and it does seem that cold weather increases osteoarthritis pain. It could be because the cartilage fluid is a little less viscous. That's one of the explanations they give. And another is that the weather is going to change with rain, because apparently the atmospheric pressure changes before storms. And that change in pressure can also be felt in the joints.
Because some receptors are more acidic.
Pressure also affects me in fractures, a little in the joints, or people who have had a history of fractures.
Interesting. So, the grandmothers were right? Yes.
It wasn't such a lie.
Hey, that thing about Plato being the first gym bro?
That's good, but honestly, there are many studies that often contradict each other, including one from about 2,500 to 3,000 years ago. Well, the sources are a bit, but it seems that Plato wasn't his name, but that the family name was Aristocles. So, a lot of people say that maybe Plato wasn't really his name, but more of a nickname that they gave him there in Greece because they said he trained a lot. He actually competed in the Insular Games, which were similar to the Olympics. Some even debate if he also took part in the Olympic Games.
Of course.
He said that the mind and the body go together, that you have to train to think better. That's what was left later with the famous, or maybe not so well-known, hypothetical ones. They were the ones who said that if I get mentally blocked, my way to get out of that mental block was to go for a walk.
The peripatetics, right? Yes, well, interesting. History also teaches you a lot when you look at it from another perspective like that.
A lot. His name was Masao Ramon y Cajal.
Ramon y Cajal, yes.
Who was another one Jimbro had adore.
Also, yes.
Yes, he competed in bodybuilding.
There are often photos of Ramon y Cajal appearing strong.
Yes, we have this perception that people who work out are rather clumsy.
The nerds or the gym bros. No, the myths and stereotypes in our minds make us think it's impossible.
Well, actually, it's super interesting. You probably know this about, the muscle as an endocrine organ. It produces brain-derived neurotrophic factor, this famous one that's a neurotrophic factor.
Yes, it's one of the few things that has been proven to prevent or delay the onset of neurodegenerative diseases through exercise. Ultimately, the muscle, as an extension of the nervous system, also, where do the nerve endings reach the muscle? It's just that we see it as something separate.
But actually, for many people, it's continuous. There are many people who say that our brains grew so much after we started standing upright. We freed our hands and started to say, now what do I do with this? And began to make tools. Or does it seem that even the motor stimulus came before the big brain?
Of course.
Of course, they're saying now, yes.
Yes, that first came the muscle, and then that made us develop at the level of the central nervous system. Another big problem in traumatology, which mostly affects, I think, younger people, and which also, for me, sometimes becomes a sentence against sports or against movement. It's patellar chondromalacia. Didn't they say I have chondromalacia? What grade is it? Are there 4 grades? Yes.
Yes, 4.
Grade 2. And therefore, I can't run anymore. I can't do squats, and I can't do X. What is chondromalacia, and what really limits you? And what doesn't limit you?
Chondromalacia, patellar or not, since chondro refers to cartilage, it's ultimately cartilage damage. It could be the kneecap or anywhere, okay? And there are 4 levels of that. Let's say level 1 is practically almost no findings. At most, it's just a little softer than it naturally would be. In type 2, cracks start to appear, and in type 3, the cracks are deeper. Some pieces of cartilage may even be lost, okay? And in type 4, that's when there's exposure. I don't know, okay?
Is the cartilage gone from that area?
There are often small areas without cartilage, typically in weight-bearing regions. Okay, so let's say that in stages 1, 2, and 3 there's no pain, because theoretically cartilage doesn't have nerves, right? So would only grade 4 hurt, or can it hurt in another grade? It's really more because of inflammation of the joint fluid, like we said about chronic inflammation, and from overloading the tendons and muscles around it. But normally it's not actually the cartilage itself. So the way to solve that pain, since it's not caused by the cartilage, is to address the structures that are being overloaded: tendons, muscles, and renewing the joint fluid. And how do we do all that? We've already talked about it a bit, with exercise and possibly with impact. The problem with the kneecap is that it's a joint that's very sensitive to extreme knee flexion, so when there's overload on the kneecap, specifically you have to change the exercise a bit.
Very deep squats, right? By the way,
normally you can do them again, but it has to be done gradually. That's why I enjoy cycling as exercise. It's typically between 0 and 40 degrees, so you don't usually go beyond that. A deep bend in the knee really stimulates the exchange of joint fluid and greatly strengthens the quadriceps and calves. So in that sense, yes, I actually use it a lot. You can see that. I'm not a sports trainer or anything like that, but I love sports. I go to watch basketball. I go to watch soccer. How about you? When you reach the field, what's the first thing you notice? Have you ever been near the players' seats? There are 2 or 3 stationary bikes.
to get ready, right before going out onto the field, right?
Right. So they do it as injury prevention because, of course, if one of those guys gets injured during the season, that's a disaster for the club. Millions.
Millions, okay? And there are notable causes against Malaysia, biomechanical causes like more knee valgus. You've mentioned weak quadriceps as one cause, but there are others too.
There are many causes. We call it the Q angle, which basically measures the axis of the joint of all the joints in the leg. So that can change due to many factors. It can change at the height of the hip because the rotation changes. Okay then? Weakness of the gluteus medius, for example, causes the leg to rotate inward, and that leads to a valgus. The knees go inward, then if the foot collapses, for example, the arch of the foot, that can collapse because of weakness in the posterior tibialis. If you look closely, the kneecap can move outward due to weakness in the medial vastus. In the end, everything is a muscle problem if you think about it. So, we can treat the symptom. Don't move, okay? I'm treating the symptom. But I don't want to treat, as a traumatologist, I'm not content just treating symptoms. That's like giving Tylenol. I aim to address the cause. If the cause is weakness in the gluteus medius, vastus medialis, or posterior tibialis, then treatment remains the same.
Of course, and do you think in Spain, I already know, but just to discuss it a bit, is there enough infrastructure in terms of physical therapy or rehabilitation specialists to properly guide the patient? You tell him, look, Manolo, your gluteus medius is very weak, you need to strengthen it. Do we really have effective systems in place?
Absolutely not. There are very few systems. The ones that exist work very poorly, and there is zero communication. Surgeon, physical therapist, patient. I recently had a case of a patient with very advanced foot osteoarthritis, the kind of osteoarthritis that's just terrible, post-traumatic, where the only treatment is to fuse the joints in the foot. So just imagine. In the operating room, we spent almost 6 hours on a patient to fuse the entire foot, placing grafts, screws, and monitoring with X-rays. All right, are you starting physical therapy? After 6 hours of surgery, the therapist just gives him a jump rope and says, "Here, jump, I'll be right back." Of course, a foot we'd spent 6 hours operating on, obviously on the second jump, that
Don't tell me that actually happened.
happened. She says the patient returned to the appointment with the entire surgery done hastily. Now what do? I cut off your foot, I cut off the physical therapist's head, I cut my own veins.
Not bad.
Naturally, that leads to, if you don't do anything, I'll see you in my office in 2 months when it's healed, and then we'll begin. So is it true that physios are super? The ones we have at the hospital, for example, during rounds, I do talk to them and I say, well, I think we can start doing this or that with this patient. Oh, well, I saw him kind of awake. I think he's going to respond there. When there's communication, yes, but there are other times when...
The missing piece is communication, nothing else. Yes, and well, in the end, it makes these patients, when you tell them, hey, your quadriceps is very weak and that's affecting your knee, they have to figure things out themselves with private initiatives, right? Find a good coach and manage on their own.
Yes?
Well, Popeye and Olivia...
That's a story too.
Popeye existed.
It's a really good story. He existed, but I also had to cut it because the full story is even more brutal.
You need to tell the full story here.
Of course. Basically, it was about how Fran Rockefriegel was called. The guy was a Polish man who had emigrated. He worked in Chester. And the guy was an activator. He moved packages of things. So apparently he had a forearm and an arm that were developed, hyper-developed. And so when the guy retired from being a sailor and all that, he really liked going to bars. And apparently he was quite a violent guy, but he was violent with a sense of ethics, because it seems he only fought, but always to defend women.
Well, you didn't have to be like that.
I mean, he would dish it out, but like an old-fashioned Dexter. No, actually, he only killed, but actually it's similar. Apparently, when I read about Popeye in Spanish, I called him Popeye, which comes from Popeye, meaning bulging eyes, because in one fight his eye socket was left half destroyed. And so he would tell that story at the bar, and a cartoonist, well, he drew it, he took his story, the honest guy. Of course, there's the issue with spinach. The American government promoted spinach to encourage people to eat it. But why did they want people to eat spinach? Well, because in a study they did, they saw that it had a lot of iron. But what happened? They misplaced a comma. And it ended up being 10 times more, right? So, they thought spinach had 10 times more iron than it actually had? What? So they spent a fortune on tests just to see that spinach is really good. It's a leafy green. It has folates, it has vitamin K, it has magnesium, but it doesn't have as much iron as
people believed. Wasn't it a calculation or chart error?
The story is great, both because of the mistake and because of...
And Olivia was there too.
Apparently, they used this man's crush as the inspiration for Olivia.
How will you come up with that story to tell it on your account? Do they come to you, do you read them, or make them up yourself?
They're things I read at some point, and I think, well, now that I'm telling stories, I'm going to bring them back from there, from the trunk of memories.
That's great. Now let's discuss the last topic, supplements. Let's be honest, especially with the traumatologist. He trusts in steel, he trusts in screws, in biomechanics. But normally, at least in my experience, he's skeptical about supplementation. Still, I have seen some trauma doctors prescribe some nutritional supplement compounds, right? Which ones really make sense? Knowing what they're good for and their limitations, which ones?
Look, one that is highly debated, even within the field of traumatology, is chondroitin sulfate. That one, for example, has been dismissed by the European agency for not having proven effectiveness, let's say. Okay? And yet the American agency includes it in the osteoarthritis guidelines as a first-line treatment.
First?
Who do we listen to? And now what happens?
Why?
Is that the issue? In my personal experience, I've actually had a good experience. I use it. It's true that I think it also depends on the degree of osteoarthritis we're talking about. Okay, it depends on the patient. I always prescribe it combined with exercise. So many times I don't know if what worked was the exercise or if it was the chondroitin sulfate. I have doubts, but I use it often, especially for patients I prescribe it to. After exercising for a while, they tell me, I'm going to stop taking it because I feel better.
That strengthens the extracellular matrix.
There aren't many conclusive studies, but it appears absorption occurs in the intestines, not the stomach. That seems like it could promote cartilage formation, but of course, in older people, cartilage formation is very limited. It's like neuron formation. It's there, but at a very small percentage.
Would any chondroitin actually reach and be absorbed by the joint?
At the intestinal level, it doesn't need to reach there. It only seems to stimulate.
Endogenous synthesis, like collagen peptides. Are there others that work similarly?
Me, for example? Well, vitamin D, when you don't reach the optimal dose, naturally. Me, for example, this week that I haven't seen sunlight, well, maybe I should be worried, right? Vitamin D and calcium basically go hand in hand. It's true, especially for older people who stay indoors. I always suggest they go outside first. Sure, but even so, they still come to me at level 15, thanks. So in those cases, yes, you really have to...
A deficiency?
Yes, and then another one that I use a lot, but that's another one of my personal campaigns, like Don Quixote style. It's vitamin C, because while it's true that the general population doesn't really need it, due to its role in collagen synthesis. It does seem to have a big effect on soft tissues, so when I perform a surgery that can have a significant impact on soft tissues, like the well-known Sudex syndrome, I usually prescribe it at doses of 500 to 1,000 milligrams a day.
I mean, at high doses, at strong doses, yes, that's right.
The problem I run into, for example, is that just like with chondroitin and sulfate, if I can prescribe it on a prescription, then it gives the feeling that it's a real medication and so on. Vitamin C, I prescribe it, I write it down as a recommendation. But is it true that since it doesn't have the backing of a prescription, or well, I have to tell them, at the pharmacy, sometimes they give you a strange look?
Yes, you can't prescribe it on the electronic prescription, exactly.
So that confuses people who are a bit, okay.
Protein, do you use it with any patients?
Protein? I usually talk a lot with patients about protein intake. I really advocate for getting it through food, especially for us, since most of us are lactose tolerant. I really love milk. Now, with all these campaigns against milk, I'm the complete opposite. I keep posting about the benefits of milk and everything. But it's true that it's very hard to meet protein requirements. So I don't really consider it a supplement, but I do think that sometimes it can be useful. But anyway, I've tried to use it with many patients and they tell me it's too sweet when it has some flavor, or it tastes like nothing when it's plain.
Trauma? I remember using Ensure, the one with beta-hydroxy-beta-methylbutyrate.
Now that beta-hydroxy-beta-methylbutyrate also... New formulations are coming that may be more tolerable. I've tried protein powder, but it's not working for me. You really have to push it. I like it, but for patients, especially older ones, it's a major barrier.
A very big one.
The shakes, let's say, well, vanilla with protein, yes, the ones we have at the hospital...
are already made.
But the thing about...
mixing powder with milk?
Or to the water, that's actually becoming more popular.
Yeah, listen. And the foreign accent syndrome, what is that?
That? Well, one of the things that fascinates me is that they say traumatologists are very rough people, right? But there are millimetric injuries that can have huge consequences. So all those things really catch my attention. What happens is that with foreign accent syndrome, which is also extremely rare, there are fewer than 100 documented cases worldwide, though there may be a few more. Well, there are people who have had either a stroke, a minor trauma, or something that has changed their brain just a little bit, or even hardly at all, playing by resonance and imaging tests. And suddenly they're unable to speak as they normally do, but they speak their language. Of course, they speak their language, but they have articulation problems. For example, they're unable to say the R, so they speak with a French accent. So what we interpret as an accent is actually very mild brain impairments that prevent them from speaking as they did before.
But this isn't related to that idea. I don't even know if it's ever happened, where someone wakes up speaking another language after trauma. No, perfect.
Infused knowledge. No, not with iTunes, nor, of course,
You wake up speaking Chinese.
as far as we know, only the Holy Spirit does that. But no, that's not the case.
Or do you, in your case, would you speak Spanish, but instead of with a Granada accent, you would speak with a good accent?
Yes, Mandarin, no, I don't know. British, no.
Yes, like him. What's this called? Gibraltar, yes.
Llanito, llanito.
Lanito is great. I love Lanito. Yes.
Well, it would be something like that. So those tiny lesions really fascinate me. I mean, discovering that a 2 mm change in correcting a knee fracture can change 80% of the weight on the ankle. That's incredible. So this guy, the one who played Superman, Christopher Joy?
Yeah, I know who he is.
No.
I don't remember, but yeah.
Then we put in the guy who played Superman, whatever his name was. He had a precise injury, as just 2 centimeters of displacement can cause quadriplegia. So those little injuries are things that I really love. I've called it the butterfly effect in some videos because that's what it is.
Is that really what you like most about your specialty?
Well, what I like the most is when things go well, like everyone else, I think, and when things go well. It doesn't necessarily have to be in an operating room, although that too, but simply, I don't know, just talking in the office, honestly, telling patients things that aren't usually said to them. I've seen 27-year-old patients who've been told to stop running.
Yes, I've heard that.
It takes me 3 times as long to get through that appointment, but I think it solves a problem.
And has your approach ever been less conservative or, well, I don't know if it's ultimately a scientific approach, but anyway, has your approach ever been criticized for going against many of the messages more?
No. Generally as a resident, maybe now as an attending. Since everyone more or less has their own patients, I take care of my patients, let's say, in my own way, of course, and my colleagues take care of their patients in their own way. So,
Of course. What do you dislike most or want to change about your specialty?
what I like least, and I'm not sure if it can change, is that we have a lot of complications that are unavoidable. They're just statistics. And for example, I don't know, infections, yes, a surgery that you did perfectly, and suddenly it gets infected and ends up a disaster. Or are the worst ones the surgeries that go wrong that don't end well? Do you keep thinking about them? Maybe. Or a fracture that you didn't see on the magnetic resonance imaging and suddenly you find it in the operating room? You might have acted differently if you knew it was there. There are many things that can't be changed on the fly. You decide where to open the fracture depending on what's present, of course. So if it's not what you thought, you can do it, but then you keep going in circles. What if I had thought? What if I had seen? But well, I think that's part of the profession, right? Yes, the whole specialty.
They have their pros and cons. Have you ever had a traumatic injury? Not you,
I have several.
but serious ones.
Well, not that serious, just a wrist fracture, a head fracture, and a radius fracture. That's because when I was a girl, I was a bit of a troublemaker, so I broke my foot and my hand. Then I had a distal clavicle osteolysis from training.
Clavicle osteolysis from training?
It's an injury that's related to weightlifting. What was I doing?
What was I doing to get injured?
Yes, bench press is one of the most stressful exercises for the acromioclavicular joint. I wondered if I tore my supraspinatus. That injury usually affects 20-year-old men who lift too much weight, but I wasn't a man, or 20, though maybe I did use too much weight.
That hurts here in the front?
The distal clavicle, yes, and it's closely related to weightlifting, but even in that case, you don't have to stop training, you just need to change your workout. Avoid bench pressing, for example, avoid bringing it too close to your chest, but that's with proper guidance.
Of course, that's what's sometimes missing. Well, and what final message would you like to leave for the audience that's going to listen to you, since almost everyone is going to hear you?
Well, that we need to do a lot of health education, that we need to stop being afraid of movement, that it's preventive, that it's treatment, and that even after a prosthesis, which is already the final stage of osteoarthritis, it still continues to be treatment. I don't think this message is said enough.
Well, There are already people like you and many others who are fighting hard to make that happen. And I think it does reach people, you know? I think it gets to people. It's another thing for it to actually happen because we have a society that makes it very difficult.
I don't remember who the economist was. I don't know if it was Warren Buffett who said the only way is the slow way because there is no other way. Well, all training is the same, but in the end, training and economics are all the same thing. I have to sacrifice present well-being for future well-being, so even if I don't feel like it, I train now for what I'm going to have in the future.
Yes, 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 and it's coming. It's sinking in, you know? We need to build infrastructures in society to make those decisions easier. I really like to do a lot of research. Lately, I've been into decision architecture, which I think was also coined by an economist. And basically what it says is that most of our decisions are unconscious, and we can influence decisions by making helpful changes to your environment without restricting your will or your freedom. So I think we need to create, as a society, facilities in our environment so that people can... The default action should be training, starting with children. Children need to have it in their minds that just like they study math, they have to train. Just like they eat, they have to train. And I think that when you carry that in your education, in the end, you replicate it in your life and you replicate it with your child.
But is it the same? I mean, I think it's the same, yes, what you're saying. The architecture of decisions is like the butterfly effect of those 2 millimeters in psychology. It's the same. It's true that the mechanics matter. For example, if you run 10K or a half marathon, reaching the kilometer mark can feel different if that's not your usual distance. At kilometer 16, you're exhausted. At kilometer 18, right? So, the psychological strength that gets you to kilometer 21 is more or less the same strength that helps you finish studying that topic. The one that gets you to train on the day you don't feel like it. In the end, it's the same thing. I feel it the same way, really.
Yeah, exactly. In the end, it's just like you said, sacrificing your present for a future, but applied to everything in life. Well,
and also if that future, if that present is exercise, it's even more so because, well, you know it. You produce a series of hormones, these, what are they called, endogenous opioids.
In the end, there are endogenous opioids.
Yes, in the end.
Being present helps, obviously. On Sunday, I have a half marathon and I'll remember you. I hope I can hold on from kilometer 16 to the end.
At 16, I start to fade. By 18, it's worse. By 21, it's just running.
Running is all about mentality. In the end, you realize that your body is constantly sending you signals about this discomfort. It turns into pain and gives you signals to stop. It keeps going. It's very mental. In the end, if your body is healthy and strong, you can run more than you think. I did it last year, which is in May of this year. I did a 100K. I had never done a marathon, and I did 100K, which in the end, you just do it. Most of it is walking. It's a trail going around Menorca. And in the end, what gets you to finish those races is your mind. Having a body that's in decent shape.
The average marathon runner is 42 years old?
Of course.
So that means there are people in their 30s and people in their 50s and 60s.
For me, if it's not there, it's even higher.
Because of the price I see.
So, guys, make sure you exercise. That's essentially the advice from both an endocrinologist and a traumatologist. Today, Ines, thanks for your time. I think we've had a very entertaining episode. I know it's been a tough week at work, so you should rest this weekend.
I hope it's educational. Well, I always try to keep the level accessible for everyone. That's drawing, not getting into very technical stuff, let's say.
That's drawing, so you do it perfectly. By sight. The results are there, so keep going, okay? You have to keep going. Thanks, everyone. Another episode of Better Than Yesterday. Hope this was helpful and you put it into practice, applying what we discussed. See you next time. Big hug and keep empowering.